Good afternoon, everyone. You're all very welcome to our Aware webinar today. So please take a moment to get settled now while we allow a few minutes for people to join us. Welcome again, everyone, to our conversation today on the Power Threat Meaning Framework. My name is Dr. Susan Brannick. I'm a clinical psychologist and clinical director with Aware. And I'm delighted to be joined today by Dr. Lucy Johnstone, who I'll introduce in just a moment. But before we get going today, just a bit of information on Aware. So for those of you who are new to our webinar series, these take place on the second Wednesday of every month on a range of mental health topics. Aware also provide free support, education and wellbeing programs for anyone affected by anxiety, depression and bipolar disorder, and including those supporting a loved one. So do have a look at our website, aware.ie, for further information on that. In terms of today in our conversations, so we really welcome any conversations that you might have. You can ask questions to us during the webinar via the Q&A box, and we'll get to them at the end of the webinar. So we may not be able to answer every question, but we'll try to answer as many as we can. So if stuff comes up to you as we're talking, please do put the questions through. So without further ado now, I'm delighted to introduce Dr. Lucy Johnstone, who is a consultant clinical psychologist. She is the former program director of the Bristol Clinical Psychology Doctorate in the UK and has worked in adult mental health settings for many years. She's visiting professor at London South Bank University and a fellow of the Royal Society of Arts. She's the author and co-author of several books and book chapters, articles, taking a critical perspective on mental health theory and practice. And Lucy was the lead author, along with Professor Mary Boyle, for the Power Threat Meaning Framework, which is a British Psychological Society publication co-produced with service users, which outlines a conceptual alternative to psychiatric diagnosis, which has attracted national and international attention. Lucy, you're really very welcome today. Thanks for joining us.
Thank you for inviting me. Yes, I've made quite a few visits to Ireland over the last few years, so I'm very pleased to be back again, even if not in person.
Brilliant. Yeah, and really looking forward to our conversation today on the Power Threat Meaning Framework. And maybe what we could do is sort of jump right into it, actually. So I suppose as we'll kind of get into the detail of it in a bit, but I guess essentially it's offering a fundamentally different perspective on the origins, the experience, the expression of emotional distress and troubled or troubling behavior. So basically it's an alternative to psychiatric diagnosis, a different way to understand perhaps. So I wonder if we might start maybe with sort of where that came from and maybe what you see as some of the limitations of the current diagnostic model.
That's a good place to start, which is, what are the limitations and disadvantages of the current model? And this is also a good place to issue a little warning. I'm going to put forward some controversial ideas. What I always say at the beginning of any talk I do, which is that these are ideas, they're thoughts, they're views. They do not have to be your thoughts or views or beliefs. And I really want people to feel entirely free to take what they want from this discussion. They may agree with some of it, all of it, or none of it. And that's up to you. But one thing that I've often been made aware of is that the controversies about our current system are not widely known. It's not widely known that our current ways of understanding mental distress are not evidence-based and has been subject to a lot of criticism over the years. So all of us in the society we live in tend to assume without questioning, because this is what we're told and this is what we read, that experiences of emotional distress, like depression, are best understood as some kind of medical illness which needs diagnosis, probably treating with pills, probably caused by something that may have gone wrong in your brain or something genetic and so on. And what people are much less aware of is there's no evidence to support this perspective. And I want to be very clear that that's not saying the experiences aren't real. The experiences are absolutely real. People do have terrifying mood swings, do feel suicidally depressed, do feel desperate, do feel overwhelmingly anxious, do hear voices, do really struggle with their lives. What I'm questioning and what the framework is questioning is, well, what's the best explanation for that? And you may have seen in the news recently that the chemical imbalance theory has been thoroughly debunked. There is not and never has been any evidence that depression is caused by chemical imbalance. What people, as I say, are often less aware of is that the very people who draw up the diagnostic manuals have been saying things like, this diagnostic system is neither safe nor scientifically sound. And as high up as the World Health Organization and the United Nations, the message is coming down, it really isn't helpful or scientifically evidence-based to regard people as having disorders as opposed to people struggling with things that are going on in their lives. So we're kind of left with a circular explanation in a way. Why do I feel so desperate? Because I have depression, clinical depression. How do you know I have clinical depression? Because you feel so desperate. It sounds like an explanation. It isn't. It does, of course, for some people bring a certain amount of relief, which is fine. I wouldn't want to take that away from people, but it also actually comes along with quite a lot of stigma often, and in our view, as author of the framework, often prevents us taking a good look at what else is going on. Maybe there are reasons in people's lives for why they're feeling like this. Maybe the diagnostic model doesn't really help us to look at that. Maybe it actually stops us from looking at in a way that is in the long term unhelpful.
I guess that, yeah, they're kind of huge ideas in a way, aren't they? Certainly this idea that there may not be an evidence base for that whole model. And as you said, that's kind of coming through from different sources. And I guess, as you say, it's really important, isn't it? That's not, and this is we'll come to the kind of some of the criticisms or the challenges to the model later. That's a frequent one, isn't it? So if you're saying that's not accurate, then you're saying suffering isn't happening, when that's clearly not what the framework is saying. It's I guess it's how we make sense of that experience of suffering. As you said, there's certainly meaning.
Absolutely. And one thing we want to do is open up choices. So we're saying you have to look at it this way, but we are saying you have the right, to know that there are alternatives. And for some people, those alternatives fit better. Yeah.
I guess there's something in there, isn't, as you say, that the kind of one potential downside of the diagnostic system is it discontinues further explanation or understanding. It's a bit of a cul-de-sac potentially in terms of, well, you have this, so that's the end of it, as opposed to, well, what might have happened in your life and what might have influenced that emerging. And that probably leads us in maybe to then the kind of maybe a bit of an overview of what the framework is. So for someone who might be kind of joining us now who's never even heard of that, I've never heard the phrase power threat meaning, but they're kind of here thinking, well, this sounds a bit interesting, but they're not in any way familiar. How would you describe it to someone who's very unfamiliar?
That does lead in nicely, because one of the simplest ways of describing the framework is that it's trying to encourage a shift from broadly speaking of you based on what's wrong with you to broadly speaking of you based on what's happened to you. That's not our slogan. It's a slogan that comes from trauma-informed practice, but it's a useful one. So the power threat meaning framework is a massively ambitious project. Bad news, it's very, very long and dense and difficult to read. Good news, you don't have to read it. You're going to be putting up resources, I think, and links to the website where there are briefer summaries of it, podcasts, interviews, good practice examples, and so on. And essentially it was put together by a group of people led by me and Professor Mary Boyle, which include service users or survivors, as people sometimes describe themselves, people who've been on the receiving end of the psychiatric system. So it's a co-produced document which evolved over 5 years, which was published by the British Psychological Society. It's not an official BPS model, so it doesn't mean every psychologist is using it or has to use it. And in fact, some people don't think it's their cup of tea, that's fine. But essentially it's our attempt to answer the question, if we don't have an understanding of distress based on diagnosis, what do we need instead? And there are lots of people already working in non-diagnostic ways, which I'm sure includes the people who run your websites. So we're not saying no one's ever thought of any of this before, but we're trying to put together a framework that's kind of bigger than all the alternatives in a way, that actually goes right back to the starting point and says, what are the very basic principles we need to draw on in order to understand people's distress in a non-medical way? because it's our belief that models that are developed for what goes wrong in people's bodies in general medicine, which work very well in lots of cases, none of us would want to go back to the age before modern medicine, actually do not work, are inappropriate, often unhelpful for what goes on in our life, what goes wrong in our lives, what goes wrong with our emotions. So a very brief way of summarizing our answer is that we think instead of diagnostic labels, we need narratives, stories, narratives, which can work at all sorts of levels. You could have a personal narrative, you can have a family narrative, you could have a social narrative. And these narratives help to make the link between people's particular, very real experiences of distress and the circumstances of their lives. And the framework tries to trace those circumstances back actually quite a long way, which we're going to discuss in a minute, I'm sure. So it's not just about, some of the stuff we already know quite a lot about, difficulties in relationships and so on. It's about looking at the whole set of assumptions of the societies we live in, about our economic and political context, about everything about our current way of life that for many people is resulting in them finding life, very, very difficult, and particularly our young people really struggling with it. That's it in a deep way.
Yeah, it's very impressive. It's a long document. It's well summarized, and I guess I was just thinking there, as you said, certainly that kind of medical model, maybe. So if you've got like diabetes, let's say there's a test for blood sugars or whatever, so that's clear. But I guess it sounds like, so this model is maybe suggesting that physical model of illness doesn't really work. Is that, and I guess
it doesn't fit. It doesn't fit.
Yeah.
And all sorts of things follow from that. We have fundamentally the wrong model. It kind of brings up for question everything about the current way we treat what we tend to call mental health problems. We don't really like that term either. I mean, it's a very controversial thing to say with huge implications, because of course diagnosis has found its way into every area of our lives in a way, hasn't it? Into the legal system, into our welfare system, into education, in the media. We seldom hear an alternative, and if you start questioning it, then an awful lot of other questions are thrown up, and it's quite challenging at a number of different levels.
Yeah, and I guess, as you say, it's what services certainly in Ireland and the UK maybe are predicated on, based on a kind of a diagnosis, which kind of includes or excludes people depending on what that diagnosis is, and as you say, has links to benefits, or in the UK maybe certainly, or kind of, so it upends a whole system. So it is quite a controversial view in a way, but at the same time, trying to make sense of someone's individual life experiences to how they might struggle in the current day doesn't feel that controversial.
Well, it's interesting.
If you're feeling quite depressed now, there's probably lots of valid reasons as to how you ended up here.
Exactly. In fact, we've had several kind of common reactions to the framework. One is, my goodness, this is long and complicated to read, and it is. But the other is, surely this is common sense, which it is. So in some ways, it's absolutely common sense. Any person in the street who you happen to talk to, and if you said to them, do you think people living in poverty are more likely to feel more depressed and miserable, would say yes. I mean, that's kind of the argument we're putting forward. And yet, as soon as you introduce diagnostic thinking, you tend to lose that common sense, lose that link, and start focusing in on the problem as being focused within the individual. And actually, this doesn't just happen medically. It's your mental illness. It can happen psychologically as well. It's the way you're thinking about things that are wrong. It's because you're not going out and kind of taking exercise, and that's the problem. So we're against individualizing explanations, not just medical ones.
Yeah, and oftentimes a lot gets located in one person, doesn't it? Or that might be quite structural, either in the family or in wider society. I guess a criticism of CBT is that you're just thinking wrong. If you can just think better. And I would say that. And I think that's a bit unfair on CBT, but I guess there is some elements of that. And I guess maybe the difference, I don't know, you can tell me what you think about this, I suppose, and we'll talk about the framework, that it's creating that narrative probably collaboratively that says the experiences of your life kind of have contributed to where you are now. I suppose the biomedical model would say that's relevant, but it's contributed to a separate condition that you have. Do you think, is that a fair way to describe it? So they, like, obviously the medical model says, yeah, that's important, but it's a contributing factor to a neurochemical or a medical condition.
Yeah.
Yeah.
That is too often what happens. So
Yeah.
a lot of people will say, well, very few people use a very narrow medical model. And I think that's true. You know, so most professionals will ask about what happens in your life and your childhood and so on. The question is what they do with that.
Yeah.
And what tends to happen is that seen as a trigger of the mental illness. So then we're off down the path of treating the mental illness like it's kind of irrelevant. And actually, a framework perspective, along with, you know, other perspectives that have been around for a long time, would be likely to say the experiences that some people might call mental illness can be understood in the light of what's happened to you. It's worth saying the framework isn't just about people who end up in services. The framework is about all of us, and we don't actually believe in a separate group of people who have mental health problems or are mentally ill, because we all face difficult lives, we all have struggles, we're all distressed at times, we all survive the best way we can.
Sure. So I guess maybe there's kind of, you touched on it a little bit, the kind of the four kind of questions in the framework. Maybe if we think about them a little bit, so sort of like what the framework actually is. The first sort of question, as you sort of said there, is sort of what's happened to you, and you talk about kind of power in that. That's the kind of the premise of that first question. Could you describe a bit about kind of what that means, or an examples of power maybe?
Of course, yes. So the framework, as I said, argues that narratives can replace diagnoses, and that can be any kind of narratives. It doesn't have to be the particular suggestion for a narrative that we put forward. People find healing through art, music, dance, theatre, poetry, and so on. But we have suggested a rough possible structure for narratives. It's not compulsory. It doesn't mean you have to use these words in these order. It's about thinking about areas in your life, some of which you may not have thought about. And so we've based that possible way of thinking about a narrative on four core questions, as you say. And by the way, in the information that people are going to get afterwards, there's a link to a book you can buy, which, if you're interested, talks you through step by step about how you might think about this in terms of your own life or the life of someone you're working with or supporting. So it's a little bit like a kind of how to put this into practice book. So the first question is, how is power operating in your life, which is a kind of expansion of the question, what has happened to you? And we think it's really, really important to look at power in its broadest possible way. So it's partly about looking at quite obvious things in a way. You know, some people had very difficult time when they were growing up. Some people may have been in a violent relationship. Some people may have had significant losses and so on. But we also want to look at things that are perhaps too often overlooked, like the impact of not having enough money to live on and not having enough resources to feed your family properly and so on. And wider than that, we also want to look at what we've called ideological power, which is a bit of a kind of fancy jargon word, but essentially what it means is the kind of worldviews, the assumptions, the principles, the ideas that we all take for granted, often without questioning them. So it's about how we ought to feel and behave and live our lives, and what do we mean by success, and what do we mean by failure, and what do we mean by, you know, how women ought to be, how men ought to be, what a normal family should be, how a happy child should behave, and so on and so on. And a lot of those kinds of what we've called ideological power are difficult to question, because it just seems to us that's the world, the way the world is, and perhaps the way the world should be. But we think that's actually a part of everybody's distress, even if it's not very obvious. And thinking about ideological power as well as the more obvious forms of abuses of power helps us, I think, to understand, again, this applies particularly to our young people, I think, why so many people are struggling when actually they may have loving families and comfortable lives and good educations and good prospects and so on. The world has become increasingly difficult, and partly that is due to the kind of worldview messages that we're all surrounded by, the social expectations and so on. Mm-hmm. So we start with power. And the reason we start with power is because power, an analysis of power, understanding of power, is missing by definition from a diagnostic understanding. The diagnosis is the problems in you, perhaps in your brain. It's also missing, as we said, from quite a lot of psychological understandings. And we want to put power back first and foremost, because everything else in the framework follows from that.
Yeah, it's interesting, isn't it? Because I guess some people may be listening to this might think, well, I haven't been at the rough end of a power imbalance, but I guess, as you say, it's a bit wider than that. Maybe, as you say, there's kind of ideological or cultural sort of ideas, or even that idea of I guess this model might suggest that idea of even the medical model itself wields a power as inclusion or exclusion, as I was saying, to services, or, I guess you hear a lot, don't you, about kind of how, well, let's say, for instance, people who might be seen in mental health services who might kind of present with a physical issue is often underdiagnosed, and there's a huge issues in terms of diagnosing physical problems in certain groups, and there's, I guess, because if there's one lens to look at things, it's very difficult. If there's, I guess, maybe we'll come to that as kind of downsides of labels or categories, if it's kind of then putting someone and seeing them in one way and what they present with.
True, and since you brought it up, I think I'm going to say something controversial.
Okay.
Which is that the framework sees the psychiatric model, the medical model of distress, as an example of ideological power in action. It's not based on evidence. It's wielded with considerable power by highly paid specialized professionals who present you, if you end up in services very often, I mean, they vary, of course, but with something as a fact which changes the nature of your identity and your reality in quite profound ways forever, quite possibly. Sure. So to present as a fact the expert judgment that you have an illness called bipolar disorder or clinical depression or personality disorder is, we think, completely illegitimate and often very damaging. That's an expert judgment, and it's not one based on evidence. So why does that happen? Well, the answer to that goes much further back than the person who's doing the diagnosing, who's probably doing what they were trained to do, and it's about the whole role of labeling in our society as a whole. So a framework narrative is very, very different because it's co-constructive. If you're not up for that, that's fine. It's about exploring together, and perhaps not even with a professional, about how to understand power in your life.
Yeah, and I guess that potentially that could be experienced as quite controversial. And I suppose, again, it's maybe worth saying that for a lot of people, like, the services that they get or the help that they get is actually really helpful as well. So it's, I guess, it's not a splitting or a negating. I guess it's, as you said at the beginning, it's offering a different perspective, and it's okay to listen to what we're saying and disagree with that, or think actually that doesn't fit for me, which is, I guess, kind of relevant to the power, isn't it? That you can say, actually, no, for me that's not right. And that's fine.
Otherwise, we don't want the framework to be a different form of imposing on people.
Exactly. Yeah, I guess that's quick.
I've worked in mental health services for many years. I hope I did some helpful things. There are many good people working in services. Not everything that happens in services is unhelpful. No. But I was interested to reading some of the obituaries about Sinead O'Connor. She was someone who was told she had bipolar disorder and later rejected that. There's lots of examples, both pros and cons, aren't there?
Sure, yeah, and I guess as you say, that this isn't about a new framework to be imposed on people. It's about kind of taking what's relevant and resonates with you and leaving the rest. And I guess that kind of first question, as you say, so that's sort of the power operating your life, and then maybe the next question is kind of how it affects you, the kind of threats that it posed.
Indeed. So I'll be briefer about this one because it'd be nice to get onto lots of other subjects as well if we can.
Sure. Yeah.
So thinking about how did it affect you, or what kind of threats does this pose to you, is a way of thinking about how do these power aspects actually impact on your life. And again, it's not just about the obvious ways. I feel anxious, I feel distrustful, I can't hold down a job. It's about the more subtle ways. I feel excluded from society. I feel there's something bad and wrong with me. No one's ever encouraged me to really work out for myself the reasons that I feel like this. So it's all of those things.
Mm. So it's the kind of what power might be in someone's life, and then how it's affected them, the threats that it posed, and maybe how they might, or how all of us might internalize some of that. So being less about external things, but this is fundamentally something wrong about me, about how I navigate the world. That might be what I take away from it. Yeah, that might be the kind of impact. And then the third kind of, well, maybe that leads into the third kind of question, the kind of what sense did you make of it, or what meaning someone made of it?
Yeah, these are overlapping questions.
Yeah.
They're kind of separate just for kind of convenience in a way, but
Yeah.
you can't think about one without thinking about the other. So meaning is the core thread of the framework. You know, everything that happens to us, you know, the impact it has on us is filtered through our meaning. If we decide that really wasn't my fault, it was bad luck, we're going to have a very different reaction to I was a bad little girl and that's why I was abused and hurt, so to speak. So it's really important to look at meanings. But again, the framework, I mean, all therapies look at meanings in a way, but the framework, again, would try to pull those meanings back up much further. So, for example, working with a woman who's been raped or abused, which, as I've done many times in my career, it wouldn't just be about challenging the common feelings of shame and guilt and responsibility, which women often carry. It was about thinking, well, how come you ended up being tricked into thinking it was your fault? You know, where do those messages come from in wider society? How can we put the shame and responsibility back where it belongs? And doing that takes us into much wider issues about women's roles, men's roles, you know, the role of society in concealing and hiding and covering up the extent of abuse in women's and girls' lives. You know, as an example, there are similar examples for men, of course, as well.
Yeah. Yeah, and I guess certainly something relevant in Ireland in terms of kind of different experiences through the last 50 or 100 years of things that have happened, and kind of the messages that people might take away with them as meaning something about them, as opposed to the culture or the influences of different power in that. I guess it's sort of, it's difficult stuff though, isn't it? It's very emotive in it. Like, these are really painful areas maybe to think about, and certainly maybe people listening now might kind of touch in on stuff. So I guess it's sort of being mindful of that too, as we're talking, because there's something in that, isn't there, that it's, as you said, kind of how the culture might kind of come together to lead us to think certain things. It's sort of a non-blaming approach in many ways, but it also, I don't know what you think about this, whether that in some ways it might then create more uncertainty in a sense, because this isn't something you, me or you as an individual can.
Well, it opens up quite a scary landscape in a way.
Yeah.
You know, what about, which kind of boils down to what kind of society are we living in? And in some ways, it's not a healthy or a helpful one, as we know. But the long-term answer is not to persuade individual people that they are ill, blameworthy, ought to be ashamed, feel guilty, and so on.
Yeah, so it's quite de-shaming, isn't it, in a way? That
I would hope so.
Yeah.
So. Yeah.
And I guess that's maybe, as you were saying, I think in the beginning, there's a whole load of very strong evidence-based work that's gone into this framework, and certainly the trauma-informed is one strand of that. That it's sort of, it takes it away from the individual person. There's this much wider kind of forces at play here, in a sense, that contribute to distress across the board for everybody. Yeah,
absolutely, there are.
So quite revolutionary in some ways, that idea.
Yes.
Yeah.
Well, again, I mean, this is not a new idea either. You know, it's the latest version of a theme that's been around since the origins of psychiatry as we know it, really. Is this about individuals with illnesses, or is it about societies that are not healthy places for people to grow up in? You know, and if it's the second, what do we do about that? It opens up huge questions, but it also opens up, we hope, a kind of freedom and an ability to make different choices, and to, if you want to, free yourself from a narrative that can actually be experienced as quite pathologizing and shameful in itself. I'm mentally ill, there's something wrong with me.
So yeah, there might be that freedom in terms of how you relate to yourself or your own experiences, and kind of bringing that meaning to them. And then, as you say, maybe wider questions about, I guess that changes the look of services potentially, of what we might want mental health services to look like, or what we might hope they could look for. But to go back just I realize I'm bringing us off a fair bit, but so I guess thinking about those kind of four core questions in a sense of the framework itself, and I suppose one of the kind of last couple of ones is what did you have to do to survive?
Yes, so this is about the area that in psychiatry or psychology might be called symptoms, but in the framework we call this survival responses or threat responses. So what we're arguing that just about everything that might land you up in mental health services, the experiences, the distressing thoughts, the behaviours that feel out of control and so on, can be understood as a response to the threats you faced, and the threats are based in abuses of power. So this is a very core aspect of the framework, is to link the threat responses or survival responses, in psychiatric language symptoms, to the threats in a way that makes sense, so that it becomes obvious. Of course I'm self-harming because that's one of the few ways I can cope with my overwhelming feelings, which are an understandable response to this. Of course I feel desperate and suicidal because that's an inevitable response to the experiences that happened some other part of my life, and it's, you know, how else would anyone be expected to feel or to behave? So it's about making it understandable. That doesn't mean it's all okay. It doesn't mean it's not very distressing. It doesn't get rid of the distress, but it provides you with a very different way of understanding it, which, as I say, can open up different ways forward. Making the link between threats and threat responses, it's another way of saying making the links between experiences of distress at a personal level, or perhaps at a family level, and ultimately issues of social injustice and inequality, which affect all of us in one way or another.
I guess again it brings that meaning, doesn't it, to what might be described as symptoms or signs of distress. As you said, they're kind of survival, or they have their roots in maybe something that was done to survive or to navigate through difficult circumstances.
Yes, or, you know, again, it could be more subtle messages.
Yeah,
as it's something that somebody did to me, so to
sure.
speak, but the kind of expectations I grew up with, for example. And I mean, again, it's it's important to say that this is about all of us, not just people who are said to be mentally ill. And this particular question draws heavily on our knowledge about how our bodies are affected. It is about our bodies, not just our minds. Our bodies react to threat. Our bodies stay on hyper alert. Our bodies can do extraordinary things like produce hearing voices as a way of shielding us from distressing memories, for example. So the framework isn't denying the role of our bodies, but it's saying we can't understand distress in a simplistic, my chemical imbalance caused my depression kind of way. And to wind up the last two questions, but I mean, you might want to start with the next question. What are your strengths? It's really important about people's strengths and resources. And the final question would be, how might we pull this together?
And I guess so how might it be pulled together is potentially something that one could do themselves, I guess, in some of obviously the material that we'll give as part of this webinar, but all the stuff that's out there. And I guess that it might be something, because I suppose the framework's not necessarily a manual. It's not
not a manual at all.
Exactly. So it's not a how-to, and it's not this is what mental health service should be, but it's more of this is a means of understanding something that's very complex.
Absolutely right. Yes. So to jump forward a tiny bit, one of the ways in which it's being received, which we're really pleased about, is that some peer groups have taken up the framework. Groups of people receiving psychiatric services without any professional support have decided to take these questions week by week, think about them together, and by doing that, give themselves the opportunity to construct new narratives. So instead of I have a personality disorder, the narrative might shift quite profoundly to I survive very difficult circumstances the best way I can, and I don't have to believe there's something wrong with my personality.
And hearing that, it sounds like that like on a common sense level, that potentially is quite a positive experience to and I guess is that what's kind of coming out of the research, or people using it, or?
Yes, I mean, our approach to disseminating the framework is to entirely leave it up to people if they're interested to use it or not use it, or approaches that they want ideas or training, if they want to think about research together. So almost by definition, the people approaching us are the people who found it helpful. But we certainly have had a lot of positive feedback from clinicians, from survivors, from ordinary people who didn't know this alternative was even available. And some of those stories, the new stories, are described in this short book that's going to be sent out as one of the links.
Which is, it's really helpful, isn't it, to see kind of how it might be in practice, because I guess it's, as you say, it's a kind of a long document, and certainly I'd have to confess to having a few goes and trying to read it.
It's okay, you don't have to.
Yeah. But I guess I guess, as you say, it's sort of translating that into something that can be useful for people, and kind of offering something different, maybe, that is trauma informed and is sort of destigmatizing and takes away that blaming from the individual, maybe. And I wonder, I guess, as we had sort of talked before today, maybe having it think about a bit of an example. Do you think maybe it's worth maybe going through that just to make it kind of...
Yes, do. So you've come up with a typical example, I think, of someone who might, it's an invented example, isn't it? Someone who might contact.
Yeah, exactly. So this is like a fictional example. So maybe just, as you said, to kind of to bring it alive a bit more. I said, so yeah, so sort of a made up example of the kind of things that might come up for people who contact Aware, or really anyone, you know, Aware or not. So let's maybe kind of talk through it, and then maybe I'll ask you kind of how you think the framework could apply. So let's say it's Marion, a 54-year-old married woman, office worker with 2 kids who are 24 and 20. Let's say she calls our support line for help. So she's talking about kind of feeling tired all the time, difficulty concentrating at work, feeling low and irritable in mood. She's had 2 previous major depressive episodes. The first when she was 18 and the second in her early 30s. Her GP had diagnosed with depression on both occasions, and she was prescribed antidepressant medication, which she found helpful. She's not taking any medication at the moment. In terms of sort of her background, let's say that she describes a happy childhood with good relationships with both parents and a younger brother. She tells us that her family were very religious. She describes herself as a worrier and often worries about her children. She reports a good relationship with her husband, who also works full time. However, she feels that she does most of the work at home. She likes to keep busy and feels guilty if she takes time for herself, although sees the need and the benefit of doing that. She finds it difficult to tell others what she needs and often feels resentful in close relationships. She's calling to speak to someone as she does not want to burden her partner or her kids with how she's feeling. So just to reiterate, if you just joined us, so that's a fictionalized kind of account of maybe someone presenting with, they're coming along for help with depression, and maybe thinking, Lucy, about how would the framework kind of help Marion? Where could it be useful for her? How would it work?
That's a really interesting example. I feel like I've met lots of Marians.
Yeah.
Okay, so the first thing to say is, as I've already said, you know, what the framework might offer might not be very different from what you're doing anyway. We're not saying we're the first people to thought of this. And secondly, it might not appeal to Marion, and that's fine. So it's about going very gently. But I think it's an interesting example because Marion doesn't have obvious reasons for feeling depressed from one perspective. So, and she's been given a narrative of, you have depression and these pills will treat it. And although she says the pill sort of worked, we don't really know what works means. Maybe it means helped her to carry on being a housewife and not question her role too much. I don't know. So the first thing I'd want to do is explore and possibly raise some gentle questions about the narrative she's been given. What does she understand by being told she has depression? What does she understand about the role of the pills? It's very common for people to be misinformed, to think this is treating an illness when it's not, although they may be helpful. The framework isn't anti-drugs, but people need to be properly informed, and they need to know there are disadvantages as well as advantages. And then I'd want to gently invite her to explore an alternative narrative. And it seems to me that, you know, this is my guess without knowing this fictional person. My ideas, they might not be her ideas, but there's quite a lot of ideological power messages going on there, it seems to me. She's got quite a strong idea about what it is to be a woman. She has to be, you know, even though she's got a full-time job, she has to put her family first. Her emotional needs come second. She even feels guilty about asking for help. That's a very common feature of the way women are taught to see themselves in their role. And I'm guessing there's a kind of Irish flavour to this as well, that maybe these stereotypes, I think they're possibly challenged a bit more in other parts, in the places I've worked in the UK, but, stereotypes vary and take a while to challenge often, don't they? What often typically goes along with that is feeling resentful. I feel I have to do this, but I feel resentful, but that makes me a bad person. I shouldn't feel resentful, which is a sign of not having challenged the narrative itself in a way, isn't it? Which I would possibly want to invite her to do. And the other area of ideological power that seems to be around is the very religious family. It doesn't say whether she's religious, and being religious can be an enormous source of support for people. So it's not about that's bad, but if we assume she's Catholic, then there are going to be quite strong messages going along with and reinforcing the kind of how women should be aspect, shouldn't there, about being a good Catholic girl and a good Catholic wife, I guess. Again, it's not about saying don't believe any of that stuff, Marion. It's about saying let's think about the messages you've taken on board. Let's think about the ones that were helpful, less helpful. Let's think about whether it might allow you more freedom if you challenge some of that. So a different narrative for Marion, if she's interested in it, might open up different views, different choices, which are not about I'm the person with depression who needs to take pills. Now, the problem, of course, is one person in a system changes, it impacts on other people. So her husband might or might not find this easy to hear because it might come up against his gender stereotypes and so on. And her own family and her children might not be too pleased. We don't know, but at the moment, my sense is she's paying quite a high price herself for not being encouraged or able to question certain ideological narratives of power. And this has been sold to her as an individual problem that is going to be solved by pills. And that is, I would suggest, giving her an extra layer of entrapment along with the entrapment of the narratives that seem to be operating in her life. My guess.
Yeah, sure. Yeah, based on the information that's there. So I guess that, and I guess it's just thinking about my own experience in clinical work, and it's harder though, isn't it? It's sort of, that's quite, I guess, what we're describing here, and whether that's maybe an exploration that someone might do, whether Marion might do that alone or in a peer group or with a professional. It's challenging, isn't it? And certainly if you're already feeling quite not in a good space, they're kind of big questions. And I suppose, as we were saying earlier, open up quite a large landscape of things that maybe we don't always think about that much, actually.
Well, we don't. Well, and more than that, the framework say we're actively discouraged from thinking about it. And if you start challenging it, then you find out that actually it's not just we don't think about it, we're not supposed to think about it. Someone like Marion, and any woman actually, might benefit from a women's group, because it's a lot to do on your own, as you say. Too much to do on your own without support.
It doesn't seem, I guess it could potentially be kind of harmful in a sense. You want, if any sort of exploration like that, you want to do it in a place where it's going to be useful and supported and contained, isn't it? Because there are a lot of big questions, but I guess it's opening up that possibility that there's more going on here. I guess that's what the model is saying. There could be more going on here than something in your brain, that you are a person in the world that's relating as such. I guess, and maybe we'll kind of leave that, Marion, there for a minute, and hopefully that's sort of been helpful to kind of think about the sorts of stuff how that might work in an individual case. But I guess you sort of alluded to it there, that idea about kind of the questions that we can ask and the questions that we can't ask. And again, that's very kind of relevant here in Ireland too, about what the kind of privileged kind of narratives, what we can question, what we can be annoyed about, and what we sort of just have to get on with and not kind of have any emotional response to. I wonder, and I guess I sort of know the answer to this because I've seen a bit of it play out on Twitter, and kind of other social media, but the responses to the framework.
Yes.
How do you make sense of them?
Well, I mean, overall, the responses have been incredibly positive. Important to start with that. There are 6 translations. I've travelled around the world talking about it, along with other of the authors, been to Australia, New Zealand, Brazil, you know, Spain, Greece, Denmark, Norway, Sweden, all over the place. There's a lot of interest, and a lot of people are taking it up in small and sometimes in bigger ways. So it seems to me this doesn't mean that the framework's perfect and the answer to all our problems, but it means that a lot of people are seeking something different. There's been a lot of quite unpleasant stuff on social media, a lot of it directed towards me personally, because I've been foolish enough to have a presence on Twitter. I've come off Twitter now because it's just getting too unbearable. But I mean, it's been quite brutal at times, and interesting. What we're accused of is more or less the opposite of what we're saying. This is about imposing trauma-formed stories on people. This is about silencing service users. This is about, you know, I mean, bizarre accusations really, and a lot of quite blatant misogyny directed at me personally by people, male professionals mostly, tweeting under their own names. It's quite astonishing. The only way to understand this, I think, is that the framework itself is a challenge to power, and no matter how often we say this is up to you, you know, the thing that's being imposed, excuse me, is diagnosis, not the framework. The framework's optional. No matter how often we say that.
Sorry, Lucy.
Yes.
Sorry, Lucy, you froze there for a second.
Okay, so no matter how often we say it's diagnosis that's being imposed, not the framework is optional, the reaction seems to me at base to be, from some people, nobody should ever have thought or written or expressed these ideas. You know, that's worrying, that's dangerous. One thing to disagree, fine to disagree, it's another thing to say this should never have been spoken about. And that, I think, can only be understood in terms of power. You know, it's the framework itself is a challenge to forms of power at various levels.
It's been, it's been quite a response, as you say, and a lot of it positive, and a lot of really interesting kind of work is happening with it, but a very kind of, I don't know if it's fair to say, a very emotive response back. And I guess, as you say, from people that would be quite well known in the mental health world, certainly in the UK, and as under their own names, it is quite shocking, actually. So it's interesting to.
It's bizarre.
Yeah,
and they should be very ashamed of themselves, some of these people.
Yeah, and I guess you know, seeing it as an observer, and I don't know what it might be like then to go into someone's clinic where you've seen kind of that play out very publicly. It's quite shocking, isn't it? So it's interesting to think of as you said, the challenge that it might present.
Yes, I do just want to say that this has been across professions and from some survivors as well. It isn't, you know, we've been attacked by psychiatrists. Many psychiatrists have been very supportive. Many psychologists, for example, really don't like the framework. That's absolutely fine. But it's not about attacking psychiatrists as a profession as such. Many of them are very aware of the limitations of their discipline. It's about a way of thinking which many people sign up to, and some are very reluctant to have any challenge presented to it.
Sure. Yeah. And I guess that's really important to say, isn't it? It's not personal, and it's not personal to services. No. It's about an idea, really, and putting forward an alternative idea that isn't about right or wrong. It's a different kind of model. Yeah. I'm just thinking about the time that we've got. We've got a couple of questions coming in, so maybe we'll have a look at them if that's okay. Let me just have a look. Okay. So I'm just trying to read this and sort of stay in the webinar, which is a bit tricky. So I'm just going to read it out. Do you think the outcomes for the person are different, and how, based on whether the mental health professionals use the diagnostic versus the narrative framework? If the person is suffering with mental health because they are homeless, or their asylum case has been rejected, or because they're separated from their children, these are obviously elements that have an impact on the person's mental health. How does a narrative framework, how might it be able to assist a person struggling with these types of issues? I guess that's sort of, touching into the kind of the reality maybe of the kind of moving from an abstract idea of power to actually kind of struggling in the world, and the day-to-day of that maybe.
Yeah. That's a good question, if I understand it right. So I would hope the framework would show very clearly, for example, that someone who has no access to resources or is an asylum seeker has very good reasons for feeling the way they do. I mean, that's a kind of example that's so obvious, you would hope that no one would miss it. Obviously, someone who is homeless and whose asylum status is uncertain is going to feel pretty desperate. I think what the framework would do that would be different from a lot of mental health services is they wouldn't say, not only are you homeless or, you know, seeking asylum and so far haven't managed to secure a place, then you also have a mental illness. It seems to me that's not only a odd thing to say, but an actually a very unkind thing to say. You know, it's refugees and asylum seekers and homeless people have every reason in the world to feel desperate. I don't even like the term mental health problems. You know, they haven't suddenly developed a mental health problem from a framework point of view. They are feeling desperate and stuck because of their very difficult circumstances. And the framework would want to say that absolutely clearly and explicitly, and really sidestep all the diagnostic narrative, which is not needed and not relevant and not accurate and not scientifically based.
It's an interesting one, isn't it? I guess, and it kind of goes back to what we were saying, that idea, so that, yeah, hopefully I'm representing it correctly, but I guess a medical model might suggest, as you say, that those kind of very kind of traumatic, potentially really challenging life situations have triggered a mental illness. Yeah. And I suppose and I guess maybe that's one of the, maybe the questions or there's some of the criticisms that come up to the model. Can this model then, I guess, for people who are kind of experiencing very profound difficulties at one end of the continuum, does this model have much, or what can it offer someone who, as you say, might be hearing voices or might be very, very impacted by and feeling very disturbed, you know?
That's a very good question. So we do see the model as applying across the spectrum. And in fact, two of our core authors, Jackie Dillon and Eleanor Longdon, are survivors who have suffered really, really extreme forms of distress that were labelled schizophrenia and things, and, you know, could easily have ended up stuck in the system for life. So if you want an extreme example, then they certainly kind of embody that. And I probably haven't presented it in a slightly simplistic way today because of time limitations, but someone in extreme form of distress is not, even if they want to, going to be in a state to sit down and co-construct a narrative. So that's not what we're suggesting in a way. And some people would rather not use words anyway. They would rather express themselves in different ways. But I think there's all the difference in the world between saying someone is unable to work with us because they have schizophrenia and someone is unable to work with us at the moment because clearly such difficult things have happened to them that, you know, they're in a state of distress where at the moment our main job is to keep them safe and look after them. And at some point you might want to very, very slowly start putting together pieces of a narrative, but you would start from the assumption that somewhere in there is a narrative. And that's a very different starting assumption from this is a very severe case of schizophrenia.
Yeah, as you say, it's a very different, and maybe a different endpoint then potentially.
A different endpoint, yeah, and you know, it can take, in a sense, narratives are always evolving. We all have our life stories. They never reach an end, you know. So it's a lifelong journey for all of us in some senses.
And maybe this question leads on to it. What are your thoughts on how this could affect healthcare settings in terms of reformulating the doctor-patient relationship, but also the fact that mood, etc., can be overlooked as a symptom of physical disease?
Yeah, well, that's an interesting question because obviously there are many situations where a diagnosis is appropriate and necessary, and some of the things that can look like mental health problems do turn out to have physical causes. You know, for example, very low mood can accompany dementia, it can accompany certain sort of hormonal disturbances or all sorts of things. It's really, really important we identify those. And in those cases, a rather different understanding is necessary. So it's not about saying a diagnosis is never necessary. We need to be very careful to, you know, make sure we've done all the right physical tests. Interesting, the framework has been taken on by some people working in general health, in physical health services, working with cancer patients, for example, or working in pediatrics, because although You would then be working alongside a diagnosis, or perhaps intellectual disabilities, Down syndrome, or whatever. You'd need a diagnosis. That would be the starting point. You also want to make sure you include the whole person. And so the framework helps us not just to see, you know, the disease process. Even when there is a disease process, it helps us to put the whole person in context and understand the particular challenges they may face in coming to terms with their, whatever it is, their physical health problem.
Yeah, and I guess how they might relate to that physical health diagnosis and what it means to them, and how it's integrated, and I guess what it might mean in the wider culture to have a long-term condition or a diagnosis of something. So that's, I guess it's kind of so kind of broadening out that narrative maybe. We've got maybe time for one last question. So I guess someone here is saying that kind of someone with recurrent depression, I've noticed a shift in recent years away from medication and towards psychology. And they mentioned compassion focused therapy. And I guess that is sort of whether that's a step in the right direction for the medical model. I guess it's a contentious for asking two psychologists that, but yeah, I'll let you answer it.
Interesting. Yeah, I mean, there are significant shifts away from the medical model. I mean, I guess from our point of view, you know, adding another layer of icing on the cake isn't the answer. We need a different cake. But having said that, if we're adding on a layer of compassion focused approaches, then great. I think a lot of compassion focused approaches are very compatible with the framework. I think the potential limitation is that they can, depending on how they're framed, also be quite individualistic. You know, need to be more compassionate for yourself. Well, great, but we need to live in a more compassionate society. I mean, Marion, the example, needs to be more compassionate to herself in one sense, but she's subject to a million messages saying, you know, as a woman, you're not compassionate to yourself, you're compassionate to everybody else. So a compassion-focused approach, I'm not sure would sufficiently emphasize that kind of analysis, although in principle it could do. So that's partly why we say the framework can add in extra perspectives to existing approaches, which have a lot to offer.
It's I guess it sort of broadens things out a bit, doesn't it, and kind of helps that meaning making. Excuse me, I'm just aware we're kind of coming to the end of the time. I wonder, I suppose, just thinking about someone listening to this who might think, God, I'm not, you know, it's quite, maybe it might be people listening who really disagree with it. It might really resonate with other people, which I guess we'd expect, and that would be quite normal. So that's, you know, that you kind of offer something, and that maybe it may be kind of resonant with some and not others. But I suppose and maybe this is a bit of a broad question, but the kind of intention behind it, or what you would kind of most hope someone might go away with from the webinar today, is it sort of like a curiosity about more, or kind of what do you think?
I hope there's been stuff to make you think. I mean, the way that the framework is really central about the ways we think. The ways we think shape almost everything else. The way we think about distress shapes almost everything else. The kind of services we offer, the kind of explanations we offer, the kind of interventions we offer. It all starts with how we think, and we're presenting a major challenge to jargon work, a particular paradigm, a whole way of thinking. So if this discussion has made you think, then fantastic, result achieved. And if it's made you think, I don't agree with any of this, that's also fine. But if it's made you think, well, there might be something in this, there's plenty of resources on the website, and you're going to get some links, and look into it a bit further and see if any of it resonates for you. And that would also be great.
Yeah, absolutely. Well, Lucy, thank you so much. I really, really appreciate your time this afternoon. In talking through, and I really hope, as I said, that that it can offer something to make people think, and maybe think about something different or new, and kind of taking of that from what you will. But I mean, a huge amount of work has gone into it, hasn't it? It's clearly growing in terms of what people are using it, and it's kind of resonating with people, and in the face of quite a storm actually as well. So thank you for your work in it, and thank you for sharing today. It's been really, really interesting conversation.
It's been great to talk. Always willing to talk about these ideas. So thank you for inviting me.
Yeah, you're very welcome. Thank you. And just before we finish up then, just a note about the webinar next month. So that is going to be managing mental illness in the workplace, a practical approach. So lots of space for kind of questions in terms of employment support, kind of managing kind of distress at work and kind of rights and entitlements around that. So if you're around, please join us next Wednesday. And as ever, we have a survey after this webinar. If you've been watching, we'll be really grateful to hear your thoughts about what was helpful or unhelpful, what you liked and didn't like, and what we might focus on for future webinars. But for now, thank you all very much. Thanks again, Lucy, and I'll see you all next month. All right, thank you.
Thank you.